Hello, this is Professor Stanga from the Retina Clinic London at 140 Harley Street. I would like to thank the Macular Society for this invitation. I feel privileged to be able to spend some time with you and share some thoughts and experience on new treatments in the pipeline for the treatment of age-related macular degeneration. These are our commercial associations. Let's remind ourselves about the eye and its anatomy. We have to remember that the eye works like a camera with a lens at the front and a film or a chip at the back. The lens, which sits behind the pupil, when it's transparent, when it becomes opaque, that's the cataract, and the lens focuses the image on the macula, which is a small area of approximately 6 millimeters in diameter in the center of the back of the eye. This is a diagram showing the optic nerve, which measures 1.5 millimeters, and the macula, the center of the macula is the fovea. These are some histopathological and OCT scans showing the normal foveal depression. So what are drusen? We talk a lot about drusen, and I'm sure you've heard about them. Drusen are an aggregation of hyaline material that's located between the Bruch's membrane and the RPE or retinal pigment epithelium on the outer face of the retina. So drusen are composed of waste products from photoreceptors, the cells that capture the image. Hypo or hyper, so too little or too much pigmentation of the retinal pigment epithelium or RPE may be present. There are different types of drusen: hard, soft, confluent, calcified. This is the appearance of a soft drusen. This is what we call high-risk drusen, soft, confluent, hyperpigmented drusen. These patients are at high risk of wet AMD. This is what an OCT scan of drusen looks like. This is the retina, the normal foveal depression, and here you can see these bumpy areas. Each one of them is a drusen. Here you can see some hard, smaller drusen. There is a particular type of drusen which is called reticular pseudodrusen, also subretinal drusenoid deposits. This drusen may be underdiagnosed. Fundus autofluorescence, imaging, infrared reflectance, or OCT are perhaps the best ways to diagnose them. And perhaps they are a meaningful risk of risk factor associated with progression to geographic atrophy or late dry macular degeneration. Let me share with you some interesting facts. Drusen and disciform or round lesions have been observed in conjunction for well over 100 years. Drusen are the hallmark of AMD. The word Druse, which is the singular of drusen, is derived from the German word for geode or potato stone. If you look at these stones, these are what we call potato stones, and they are hollow inside and they have crystals in the middle. So the origin of potato stone comes from the early 19th century, and the earliest description is by William Buckland, a geologist and Dean of Westminster. So let me share with you the AREDS or age-related eye disease classification of AMD. We have category 1 when there is no AMD. There are no or few small drusen less than 63 microns in diameter. Category 2, early AMD, there's a combination of multiple small drusen with few intermediate drusen from between 63 to 124 microns in diameter or mild RPE abnormalities. Category 3, intermediate AMD, any of the following features: numerous intermediate drusen, at least one large drusen, 125 microns or larger in diameter, or geographic atrophy. Geographic atrophy is when there is cell death already. RPE atrophy not involving the center of the fovea in this case. Category 4, advanced or late AMD, one or more of the following: RPE atrophy involving the center of the fovea, neovascular maculopathy including choroidal vascularization or CNV, serous or hemorrhagic detachment of the retina or RPE, retinal exudates, subretinal or sub-RPE fibrovascular proliferation, disciform scar or subretinal fibrosis. Please note that 124 microns is the average diameter of a retinal vein at the margin of the optic nerve head. Small drusen also are frequently seen after the age of 50. So this is perhaps an epiphenomenon associated with aging. Intermediate drusen, however, are more specific of AMD. Category 4, advanced AMD, in this case, showing progression of geographic atrophy over 29 months with also CNV. We see here geographic atrophy alone, and here towards the end of the 29 months, subretinal hemorrhage and fibrosis. These are all characteristics of the association, in this case, of wet AMD with dry AMD. Let's compare dry versus wet AMD. Dry AMD is also called non-exudative, non-neovascular, or geographic atrophy at the advanced stage. The pathophysiology is drusen-related, and it's the end stage is geographic atrophy. It is a slow, insidious disease. The treatments at present are at the research phase. There's lifestyle advice and ocular vitamins, of course. Wet AMD is also called neovascular or exudative. The pathophysiology is VEGF-mediated CNV, and the end stage is a disciform scar. There's rapid or severe loss of vision, and there are treatments that are already commercially available and very successful indeed. So how prevalent is geographic atrophy or late dry AMD? In the UK, late AMD in aged 50 years or over, the prevalence is 2.4%. It increases to 4.8% in patients over the age of 65 and 12.2% in those over the age of 80. The prevalence of geographic atrophy ranges between 1.3 to 6.7%, and the prevalence of wet AMD 1.2 to 6.3%. Therefore, the prevalence between the two diseases or forms of disease is now considered to be very similar. 39,000 people develop wet AMD in the UK each year. If we consider the population of the UK to be 60 million, that is 663 new cases per million per year. 50% of those with unilateral geographic atrophy or late dry AMD demonstrate bilateral geographic atrophy within 7 years. GA is also common in patients with wet AMD. Wet AMD is effectively treated with anti-VEGF. However, there's a frequent association of geographic atrophy and wet AMD within 5 years of patients starting anti-VEGF therapy. There are no approved treatments so far for geographic atrophy. So what are the initial symptoms of AMD? Blurry vision, distorted vision, objects appear to have the wrong shape or size, a central scotoma or central blind area. What functional assessments do we do? Well, the most important one is, of course, assessing vision. And for this, we use the ETDRS grid. This has a standard format. There is equal number of letters per row, equal spacing behind the letters. It's a standardized test at a standard distance and brightness. You can see one right behind me. How do we examine patients? We, of course, do slit-lamp biomicroscopy. We use this microscope, which focuses a beam of light. We use magnification and filtering options. With it, we can see the external and internal structures of the eye, and we place a lens in front of the eye, a handheld lens. We also need to use indirect ophthalmoscopy. It is important not to limit ourselves to examine the macula. We have to examine the entirety of the retina. It's important to rule out other diseases or lesions that may require monitoring and treatment and may be independent from age-related macular degeneration. And the only way to see the entirety of the retina is to do indirect ophthalmoscopy. So we wear a head scope and we place a lens in front of the eye. we strongly rely on ocular imaging. And these are the techniques we use in AMD: optical coherence tomography, or OCT, fundus photography, fundus autofluorescence, fundus and fluorescent angiography, and OCT angiography. Some of us, we tend to use ultra-wide field imaging, multi-wavelength ultra-wide field imaging, and now the new wide field OCT. This is work that we published back in 2014 with the first use of swept source OCT, a new technology that allows improved visualization through opaque media, through cataracts, for example, and increased visualization of the choroid, where where choroidal vascular membranes in wet AMD are mainly located. Here we can see an example using swept source OCT imaging through a layer of hemorrhage in a patient with wet AMD, and you can see the subretinal hemorrhage very clearly and a hemorrhagic pigment epithelial detachment under the retina, some subretinal fluid as well on the edges. We've now also moved to ultra-wide field imaging. This is the new classification that we published with a group of international authors. We've been using OCT angiography for a while. This is a publication from us from 2017. With OCT angiography, sometimes we can observe features of the disease that we cannot see with fundus fluorescent angiography. Here you can see the correlation between the two techniques in the same patient. Here you can clearly see the choroidal vascular membrane like a C-fan, which we do not clearly see with fluorescent angiography. There are some artifacts that can appear in OCT angiography. This is not for every patient, but it provides complementary information and it is non-invasive. We are currently using wide field OCT angiography and topography. And here you can see the correlation between ultra-wide field fundus fluorescent angiography with injection of dye in the vein of the arm and non-invasive, non-dye, single scan 23 millimeter long wide field OCT angiography. For the assessment of geographic atrophy, we nowadays prefer multimodal assessment. We rely strongly on fundus autofluorescence, which more clearly defines the area of cell loss, and we of course also rely on high-resolution OCT. We can see these window defects, light going through the atrophic RPE. So, what treatments are available so far? Well, for wet AMD, there's a series of approved therapies. These are all commercially available. Bevacizumab or Avastin, this is off-label, not licensed for intraocular use, not available in the NHS. We have to remember that this started as a drug for colorectal cancer. It is the cheapest of the available drugs. There are, of course, better alternatives at the moment. There's ranibizumab or Lucentis, aflibercept, Eylea, and the new brolucizumab or Biovu. I think nowadays the most commonly used one is aflibercept of Eylea, which has significantly longer duration compared to Avastin and Lucentis. For all these drugs, we do 3 monthly intravitreal injections to obtain a loading dose, and then as required at every follow-up visit. Ideally, we should start treating earlier than late AMD, earlier than when there is choroidal vascularization in wet AMD, earlier than when there is geographic atrophy or cell loss in late dry AMD. So there are some treatments that are being investigated for intermediate AMD, like photobiomodulation, This is not approved by NICE yet, nor the FDA. It's undergoing further US clinical studies. It is approved by the EU. There is a CE mark associated. So there is 3 wavelengths that we can, with which we can illuminate the back of the eye with this device. And the idea is to try to stimulate some of the enzymes within the retinal pigment epithelium cells. There's been some basic research carried out, as well as a double mask study. So the Lightside 1 study showed that 50% of patients treated with photobiomodulation demonstrate more than 5 letters of gain, that there's been some improvement in contrast sensitivity and reduction in drusen. Earlier stages of dry AMD with no central foveal involvement of geographic atrophy showed more significant response to treatment. Retreatment is needed for a continuous benefit. There's been no safety concerns so far. Of course, further studies are ongoing. 2RT is a non-thermal laser, a pixelated laser. The beam shows a pixelation, so not every single dot within the spot of laser shows the same intensity. It selectively targets the retinal pigment epithelium to stimulate an intracellular mechanical action, again with the aim of increasing the permeability of Bruch's membrane and reducing drusen, which are the hallmark of age-related macular degeneration. This is the lead study, the largest study done so far with this technology, and the follow-up study, which showed promising results. Again, further investigation is needed. So what is going on in dry AMD? We know that a dysregulation of the complement system can be a major contributor to late dry AMD. The complement system is part of our immune system. There's evidence in drusen from multiple components of the complement pathway. There's genetic evidence, multiple genes of complement proteins, and there's initial clinical data from studies by Apellis and the effect of on the lesion growth of geographic atrophy at 12 months. And I'll talk about this more in detail later. Let me show you the results from the first Apellis study, or FILI. Now, this is the cascade of the complement system in geographic atrophy, and you can tackle the cascade at different levels. I'll talk to you about a couple of drugs that are being investigated: pegcetacoplan with Apellis and Zimura. In the FILI study, with the use of pegcetacoplan, patients were randomized to monthly or every other month intravitreal injections versus sham. This is the largest phase 2 geographic atrophy study with 246 patients. Pegcetacoplan met the primary endpoint. It reduced GA lesion growth at a rate of 29% monthly and 20% every other month over 12 months. In the second 6 months, there's been an increased response to the treatment, going up to 45% monthly and 33% every other month. The effect is evident also when we compare with a fellow untreated eye. Only one eye of each patient was treated. Treatment effect was maintained over 18 months. GA growth increased after cessation at 12 months as expected, and this meant the need for continuous therapy. Currently, there's a phase 3 study to define further efficacy and safety. We are part of this phase 3 study. Zimura, or avacincaptad pegol, or is a complement C5 inhibitor. So it works down at lower down within the complement cascade. And this is a drug developed by Iveric Bio. So the GATHER1 pivotal clinical study was a randomized, double-masked, multinational, sham-controlled clinical trial. It looked at the primary efficacy achieved by Zimura at 2 and 4 milligrams, and it showed 27% reduction of GA growth over 12 months. There's now an ongoing phase 3 multicenter trial looking at this same drug, Zimura. 400 subjects are being enrolled, and there's a comparison between Zimura versus sham for 24 months with a randomization 1-to-1. Let's talk a little bit about gene therapy. What is gene therapy? It is the introduction of genetic material into cells to compensate for abnormal genes or make a beneficial protein. If we insert a gene directly into a cell, usually it does not function. So we need a carrier called vector to deliver the gene, and we use certain viruses as vectors or carriers. So viruses are modified so that they can't cause disease when used in people. Adenoviruses are more commonly used, and the vector can be injected or given intravenously or directly into a specific tissue in the body, for example, directly into the eye. These are the results of a large study using gene therapy in X-linked retinitis pigmentosa, which we published in February last year in Nature Medicine. This is myself operating. Let me show you how we do gene therapy. We do a surgery called vitrectomy, where we go inside the eye, remove the gel, the vitreous that's in the middle of the eye, and create a bleb under the retina and inject the vector directly under the retina, very close to the macula. And here I'm using intraoperative OCT. You can see the bleb developing. This is the cross-sectional view of the bleb that I'm inducing very close to the macula. Robert McLaren from Oxford is the chief investigator of this study, and here I'm presenting at the 2019 American Academy of Ophthalmology annual meeting, where we got the Best Paper Award for this work. We know that a rare variant, rare genetic variant, and low complement factor I levels correlate with advanced dry AMD. So we've got a series of studies, the SCOPE, which is an observational study, and we've got FOCUS, HORIZON, and EXPLORE. These are sponsored by Gyroscope Therapeutics, which are interventional studies. We treat patients. These are studies evaluating the safety of GT-005 for the treatment of geographic atrophy, with the aim of slowing down the progression of geographic atrophy. This is a one-time gene therapy aiming at rebalancing an overactive complement system by increasing production of CFI. The aim is for the eye to produce its own therapy so that we do not need to inject the eye every month or every other month. And this is myself carrying out one of the surgeries in dry AMD, gene therapy. The procedure is done exactly the same as I've shown you in the previous video. So what do I expect from gene therapy in the future? Well, that we can deliver it either through vitrectomy or suprachoroidal surgery, which is a shorter and less invasive procedure than vitrectomy, perhaps earlier surgical indication when patients are still at the stage when there is good vision, day case surgery, local anesthesia with intravitreal sedation, short operating times of 1 hour, and fast patient recovery. We are already at day case surgery under local anesthesia with sedation and an operating time of 1 hour. So we are already there. This is how the suprachoroidal approach is. With this cannula, we deliver the genetic material by going with the cannula between the wall of the eye and the retina and creating a bleb from outside the retina rather than through the middle of the eye. A lot of people ask about stem cells. And let me discuss with you this work presented by Christopher Riemann from the University of Cincinnati at this year's 2021 ARVO annual meeting. This is subretinal transplantation of human stem cells-derived RPE cells. So this is a product called OpRegen, and this is a phase 1 trial. So OpRegen is administered as a cell suspension. FDA has already granted OpRegen Fast Track designation. The primary objective of this work was to assess safety and tolerability, and the secondary objective, cell survival and effects. So there's been 4 cohorts in the study. 1, 2, or 3 included patients that were legally blind with a vision of 660 or lower. That's the big letter, the first letter in the ETDRS chart. The cohort 4 included patients with better vision and smaller geographic atrophy. All patients required a short course of immunosuppression prior to the procedure. Eyes with the poorest vision were implanted with 50,000 to 200,000 cells. The treatment involved a vitrectomy surgery or the gyroscope orbital subretinal delivery system, which is the cannula I've just presented to you. So in cohorts 1, 2, and 3, there's been no marked or sustained reductions in vision. The 5 patients in cohort 4, however, showed improved vision up to 1 year of follow-up. 1 patient even experienced 10-letter gain sustained for 15 months. There's been improved drusen and RPE appearance within the area of OpRegen transplantation. So these are very promising results. Again, this is still at a research phase. From the point of view of wet AMD studies, I would like to mention faricimab, a drug being developed by Roche Genentech. This is a novel antibody that targets both angiopoietin-2 and VEGF-A. There's been a phase 2 steroid study that showed effective maintenance therapy for wet AMD with dosing intervals at 16 weeks. This is a significant increment in interval between injections. Phase 3 of Tanaya and Lucerne studies compared faricimab every 16 weeks versus aflibercept or Eylea every 8 weeks. This is what the molecule of faricimab looks like, and this is the first bispecific antibody designed for the eye. So what is the potential for a drug like faricimab that has 2 targets? Well, it effectively addresses both vascular leakage, inflammation, and fibrosis. Currently available anti-VEGF drugs only address vascular leakage. They do not address inflammation, they do not address fibrosis, and therefore we dry up the macula, but the development of scarring or fibrosis can still lead to loss of vision. We are hoping that by also increasing the interval between injections, there's going to be less need of monitoring and injections per year, and these will significantly reduce the burden of treatment. It would be impossible to list today and to discuss today all the available studies and drugs that are in the pipeline for the management of AMD, both dry and wet. However, there are several new potential therapeutic options for the treatment of both wet and dry AMD. With regards to wet AMD, there are new potential drugs with longer intraocular half-life, lower costs, and more significant anti-angiogenic activity. We know that currently available drugs for the treatment of wet AMD work. Now, what we are all looking for is to extend the interval between injections. Perhaps the biggest leaps forward at the moment are being achieved in the treatment of dry AMD. This is very exciting because for years, people with dry or late dry AMD with geographic atrophy and loss of vision have been told that there's no treatment available, no need of follow-up. Now, the situation has changed. People with late dry AMD and geographic atrophy need to be seen, and they need to be referred for assessment and possibly, if the patient is interested, enrollment into studies. There are several studies at several sites in the UK going on, looking at therapeutic options to slow disease progression or reestablish retinal cells, either through gene therapy or stem cells. So I highly encourage you to contact your eye specialist or optometrist so that you are referred. Thank you very much to the Macular Society for this invitation. It's a pleasure to share this time with you, and I'm very pleased to answer questions. Thank you again.